moving on to Dr. T. Sloane Guy. Um, I'm really excited to hear your talk and learn about the full spectrum, and also from your recent visit to the Society of Robotic Surgery where you were at last week. So this is going to be really exciting. You have the floor.
Thanks so much. Can you hear me okay? Great. So what I'm going to talk to you about today is something I'm really excited about, which is a real explosion of robotic surgical systems in development and how it might apply to cardiac surgery. And I liken it to the Big Bang or the beginning of the universe, because I think that's really where we're at. Even though surgical robotics has been around for about 30 years, it's sort of been dominated by one company primarily, and that's changing very rapidly. So the first thing I did is I went to GPT and asked it to generate a couple of images. The one to the left is I asked it the question, what is surgery in the future going to look like? And that's what it generated. I mean, isn't that incredible? You know, that was inconceivable even 5 years ago. And to the right, I put in the search term robotic heart surgery, and that's what it came up with. And I think that we're just seeing some really exciting things going on here. So most recently, Intuitive Surgical, which has dominated the field for about 30 years, came out with the Da Vinci 5. And it's really a masterpiece of a paradigm that had started in the late 1990s, and the culmination of all the lessons that they've learned over years. It's really a really excellent robot. Unfortunately, it's not currently approved for use in cardiac, but we hope that it will be soon. Now, this is what I call the robotic surgery universe. And what's interesting about this is that I've given this talk, I think, about 3 times in the past 2 or 3 months to various groups. And what I've noticed is that every time I give it, even if it's 2 weeks later, I have to update it because there's been developments. There's been new companies that have come out or, you know, come to the public light. And it's really amazing. So if you look at this map here, you see in the United States, you know, Medtronic, of course, Intuitive, J&J, Transenterix, Vicarious Surgical, and several other companies. In the European space, you've got Cambridge Medical Robotics, or CMR. In Spain, you've got Rob Surgical. In Germany, you've got Avitera. And in India, my good friend Sudhir Srivastava started a company called SS Innovations that's built a really nice robot. China is really getting into surgical robotics, and you can see here there are several companies in China that are developing robotic systems that are quite credible, to say the least. South Korea has the Mir company, Metacoroid in Japan. So really it's exploding worldwide. And this is for many reasons. One is I think everyone now recognizes that robotic surgery is the future, and everyone wants to get on board. And they also want to make it more affordable. And I think all of us are anxious to see more than one robotic system around. The robotic surgery universe is really part of a robotic surgery galaxy, which is part of an even bigger world of robotics in healthcare and robotics in our daily lives. I have no doubt that by the end of my life, I will have a humanoid robot caring for me. And this is just a small number of all the robotic surgical platforms that are out there. If you look at the surgeon consoles, there's a lot of innovation going on. One of the big trends is open console, which I think was primarily done to appeal to laparoscopic surgeons, to make it look, smell, and feel more like the surgery that they had done. But also, there's an argument to be made that perhaps it allows you to connect to your team more effectively. There's also a lot of work being done on the masters. In other words, the master slave that your fingers go into when you operate the surgical robotic system. And I've seen it all, everything from Cambridge Medical Robotics, where it looks very much like a video game controller, to at one point Verb Surgical had an egg-shaped controller, and many other designs that you see here. I can imagine eventually we may actually have personalized master controllers where, say, Danny Ramsey uses his own unique one that's different than mine because I prefer one over the other, and he does too. I see that coming. There's robotic arms. There's not been as much innovation as I'd like to see. The majority of them still are straight shafted instruments with many degrees of freedom at the tips of the instruments. I think all of us eventually would like to see what we call in robotic engineering snaky arms, where there is many more degrees of freedom within the arm. But right now, almost all the systems are limited to these straight shafted instruments, but there's still innovation going on in that space, and there are a couple of extra degrees of freedom in some of the different systems. Now, this was the platform that I personally worked on. And essentially, if you look at what's happening, the two traditional robotic companies were Ethicon and U.S. Surgical. I'm sorry, non-robotic companies that supported laparoscopy. And they watched Intuitive Surgical grow and grow and grow and gain more and more share of the market. And they finally said, look, we've got to do something. We've been against robotics, but obviously robotics is growing. And if we don't get into it, we're going to get supplanted. So Ethicon, which is part of Johnson & Johnson now, started this project with Google to build what originally called Verb Surgical. And the concept here was to have a robotic system that was integrated within the operative bed. In other words, the bed and the robot were one and the same. Since then, Google got out of it, and Johnson & Johnson acquired Fred Moll, the founder of robotic surgery, really, and the father of robotic surgery, his company, Auris, and the Atavia robot, which is what they had come up with. And it was very interesting because they came up with a very similar design, which was a bed integrated robotic system. As a result, Auris really sort of took over, and Verb was phased out. But some of the technology within Verb was phased into the Auris robotic system. This is the Transenterix. This was the first non-intuitive FDA-approved robot in the United States. And it was really built on the premise that it wanted to appeal to laparoscopic surgeons. So these were straight-shafted instruments without wristed, robotically controlled instrumentation tips. And I think that's really its Achilles heel, because the real power of robotic instruments is the ability to move the tip of the robotic instrument just like you would with your normal hand and a normal instrument as you would do standard open surgery. So it's been fairly limited, but nonetheless, it was the first to introduce the concept in the United States that there could be other robotic systems. And they've got designs on possibly coming up with systems that do have more degrees of freedom and smaller instruments, even 3 millimeters. Cambridge Medical Robotics is one of the more fascinating companies, and they came up with a system where each individual arm is a separate cart. And there's been a number of companies that have come up with this since then, but they were sort of the first. And I think that they are going to make a big impact in robotics. It's a very good system, and really introduce the notion that you don't need to have one bedside cart with all the arms coming out of it. And here you see their master controllers, which looks very much like an Xbox or PlayStation controller, which is kind of cool. This is the Kangju robotic system from SageBot in China, and I recently took this picture at the Society of Robotic Surgeons. They didn't actually have the robot there, but they had this model of it, and it looks very, very intriguing. And what was most intriguing about this, even though I've kind of become obsessed with new robotic systems, I'd never heard of it before, and yet they're developing it. This is another robotic system from China, which is a single port system, and I thought that was pretty interesting. It's got these sort of huge arms coming down, but the instruments themselves are quite small, but unclear where single port technology versus multi-port technology is going to go. The MedBot microport system is very interesting. It looks very similar to the Intuitive Surgical system. What was interesting about this company to me is seeing that they've made a commitment to build a variety of different types of robotic systems, including catheter robotics, et cetera, and not just you know, an intuitive like multi-use robotic platform. So I think this is a company to keep an eye on. Of course, the other big laparoscopic company was U.S. Surgical, which became Covidien, which then became Medtronic. And Medtronic started developing this, I don't know, close to 10 years ago, the Hugo robotic assisted system. And they built a very nice robot. It has individual arms, individual carts for each arm, which opens up the possibility of redesigning some of these operations. They've also made a big commitment to what's called digital surgery, where, as Danny mentioned, you know, the cases are recorded, but also analyzed to look at performance, et cetera. And I think that's going to become a big part of our immediate future. Titan Medical was one of the early efforts to try and bring another robotic system to fruition. Unfortunately, it really became more of a holding company for IP, which was then licensed out to other companies, but again, was one of the early efforts. Vicarious Surgical, I think this is the coolest looking robot out there. You know, it sort of looks like an insect. It only has 2 arms plus the eyes, but I think that this type of robot will probably be more common in the future. Of course, Intuitive itself has made some paradigm shifts. This was probably the biggest one they've made, which was the SP, or single port system. It's a 25mm port, and really is a great device. Not used currently in the chest, but I think has great potential. Sudhir Srivastava, who, as a disclaimer, was my surgical partner in practice years ago, and someone I respect a great deal, has had this almost religious zeal to build a surgical robotic system that could be used affordably throughout the world. And he developed the MAN system in Delhi, in India. I recently visited and looked at his system, and it's truly remarkable what he's done. They've recently come out with their 3rd generation, the Mantra 3 robotic system, and it has, I think, the potential to bring robotics at probably about 1/3 of the cost of the Da Vinci robotic system. And in cardiac surgery, we're particularly interested in his system because he is a heart surgeon, and he is embracing a number of robotic cardiac instruments, unlike most of the other companies, which are not pursuing cardiac as their primary focus. And they've come up with some innovations, like the idea of using an Olympus scope that can be manipulated in 3 dimensions. Here are some of the robotic cardiac instruments that they have produced. One of the more interesting one is the Nadi, which is an automatic coronary artery suturing or anastomotic device, which here's a picture of the actual instrument, which is based on a prior company called Cardica, where basically you could connect coronary arteries directly to bypass grafts in an automated way. And this may make total endoscopic coronary bypass surgery feasible. They also came up with a multi-fire clip adapter, which is kind of cool. So lots of innovations with what we call end effectors in robotic engineering. So this is another company, Rob Surgical. This is interesting. The robotic system is sort of a tower that comes out of one post, and each arm is basically coming off at a different horizontal plane. What I thought was interesting about this robot is that it's less likely to cause arm collisions. So, you know, there's just tons of different things happening. This is the Metacoroid system in Japan, the Hinatori, really cool robotic system. Interestingly enough, Japan is the only country in the world that actually reimburses robotics at a premium relative to a non-robotic case. In most other countries, including the US, the hospital and surgeon are reimbursed at the same rate, no matter how it's done. Another exciting project is the Renovo Carina surgical robotic system in China. I recently got my hands on this, and it's got individual arms with individual patient carts, What's interesting about this system is it allows you to use up to 6 different robotic instruments, including the camera. So that this robot introduces the possibility of having a true surgical assistant for the first time. Here's the mirror company, Revo, very similar to Intuitive, another robot coming from China. So China is clearly making a big push towards robotics. Never discount the Germans when it comes to engineering. This is the Avatera robotic system, and it's got a lot of cool engineering in it. This is a system called Myra, and there's been a couple of big items in the news recently. One was when they used a smaller version of the Myra actually in the International Space Station to test it in space, which is really cool. And also recently did a series of remote testing over a 500-mile distance to show that remote telesurgery, which was the original goal of the robot, would actually be feasible now because of improvements in telecommunications. In terms of cardiac surgery, I think the real future will actually be robotically controlled catheter systems. Fred Moll, the founder of Intuitive, also founded Hansen Medical, which had a robotic surgical catheter system, which is now part of RS and J&J. I think that there will be a number of different companies like Capstan Medical, which will come out with robotic surgical systems that will deploy transcatheter, mitral, aortic valves, etc. The technology to actually do an autonomous transcatheter aortic valve replacement probably already exists autonomously. So number of tech developments, just to wrap this up, flat screens with open consoles, some are using 3D helmets, lots of different master controllers, lots of new instruments, lots of competition now, digital surgery with quality improvement being built into looking at the recordings, modular systems, robotic arms built into the bed in a couple of different cases. Cost reduction is going to be huge. I mean, we can't afford $3 million robots, okay? New financing models for hospitals, haptic and force feedback. The new Da Vinci 5 for the first time has introduced force feedback. Several other systems being developed do have haptic or touch feedback. Autonomous and assisted functions, I think that's definitely coming. Global competition, possibility of a true robotic assistant where there'd be another surgeon at a different console operating different instruments, such as the system in China, and of course, catheter robotics. This is another interesting use of AI, which is Apella. It's a company I recently became aware of, where they're actually using computer vision to analyze what's going on in the operating room. It doesn't have to be robotics, but basically it will give the team and hospital management a real live view of what's happening in the operating room. So if there's massive delays in the operating room, this AI bot will tell you who's to blame, which is currently very difficult to do in the current environment. So opportunities in AI and robotic cardiac surgery, I think number one, surgeon and team performance evaluation. That's already starting. We already get a feedback from Intuitive now on the timing of our cases, but that's just the tip of the iceberg. I suspect one day I'll finish a robotic mitral and I'll get a little pop-up screen that says, Dr. Guy, you put in your annuloplasty ring 10% slower than the guys at Mayo Clinic or something like that, you know, and that'll cause me to prove human performance enhanced. Human beings are limited. We all know this when we drive our cars, or in my case, when I fly an airplane. There's a lot of bells and whistles that allow you to perform better than you could in an analog fashion, and the sky's the limit there. Intraoperative decision-making support, you saw some of that from Dr. Agami, looking at suggestions that could be made in the operating room, you know, cut here, do this, do that, don't do this. Autonomous task performance, I don't ever see a robot completely do an operation by itself with no supervision whatsoever, but I do see a robot doing a specific task, you know, place this percutaneous annuloplasty ring, and here's where I want you to place it, and you hit a button and it does that. I think that's coming. Intraoperative situational improvement, no-fly zones where, hey, you know, the liver's over there, the robotic system's not going to allow you to go into that space. And then telesurgery in remote locations. You know, if we ever do colonize Mars, and there's not a surgeon there and somebody needs their appendix taken out, you may need a robotic system that can do that. And that's going to require AI because of the latency involved in telesurgery. So robotics is here to stay, and you know, people can get on board or get left behind because it's going to be the big thing in the next 20 years. Thank you.
Dr. Guy, that was fantastic. You know, the cool thing is that you're a pilot and I'm a pilot. And today you showed us a lot of airplanes, right? You moved from Da Vinci or the intuitive 747 Beast, which is not quite a F-22 yet, but with the Da Vinci 5. So I think, you know, what's really what really I'm trying to understand is with all these really beautiful systems out there, whether they're single port, multi-arm, faceted or all in one, what do you think is, not allowing us to accelerate the adoption of AI to the point of even semi-autonomous? And what do you think that gap is, and how do you think we can bridge it?
Well, I think I think there are many impediments. One impediment is cultural. I think that fundamentally patients have a sense that maybe they don't want a robot doing their surgery. They want to ensure that there's a doctor performing their surgery. And I've gotten that question many, many times from patients, which is why I know it to be a fact. And my answer to that has always been, listen, the robot's not doing your surgery. I'm doing your surgery. Just like when you drove your car here, you know, and you turned your steering wheel to the left, you're not really anymore turning your wheels to the left. You are signaling to a computer, which is then executing that decision. But autonomous surgery would be different. So I think there's going to be cultural resistance to it. Okay. The second, of course, is the stakes are high. So it's one thing to make an autonomous drone or whatnot. It's another to make a surgical robot that could actually, you know, hurt a patient. But, you know, as you know, I have a Tesla that has the autonomous driving beta function to it. And I don't think many of us could have imagined that in that space where certainly people can get hurt if it goes wrong, that anyone could really pull that off. But yet Elon Musk, you know, did that. And so I think that it's going to happen, but there's going to be resistance. And I think we have to take baby steps, and look at, as surgeons as a group, maybe look at a simple task that could perhaps be automated and perhaps would add value because a computer or a robot can do it more efficiently or better than we could. I don't know, throwing a stitch, tying a knot, who knows? But it's going to be an uphill battle for sure, but it's going to be ultimately won.
Yeah. I see a friend standing by. Go ahead,
Yes.
Andrew.
Yes. So I'm actually about to get on a plane here, and you're both you guys keep talking about being pilots. Do you guys know what Autoland is? Not the car part company, but Autoland. So I was flying back from a meeting in Houston a few years back, and we were in a big plane, and it was a rough landing. And the pilot actually got on, and he said, you know, sorry about the landing, but we decided to use the artificial intelligence. So, you know, I always think when people tell me like we'll never do autonomous actions in the operating room, you know, basically they just had 300 patients, they didn't get our consent, and they put us all at risk, and it, you know, it happened. So at the end of the day, what we think is going to happen, what we want to happen, it's not going to be up to us unless, you know, we're all over it, which is, you know, the point of the journal, and which is why I'm so happy that you put on this webinar for cardiac surgery. But were you guys as pilots aware of Autoland, like this program that does autonomous landing of you know, passenger jets?
Yes, and you know, autopilot's been around for a long time. But what's interesting about my flying career is that I flew airplanes about 35 years ago avidly before the autopilot was well developed, before a lot of computer assistance was available. And then recently in the last year, I've begun flying again for the first time in many years. And what amazes me is how you can darn near have an airplane take off, go somewhere and land almost autonomous, even with current technology. And what's even more disturbing is that in some cases it's better than a real pilot. And perhaps that's the reason your pilot did that, is because of the weather. They thought it would be safer. But there's no doubt that there are things that computers can do better than we can.
You know, what's really important is having the human in the loop. So maybe your landing, Andrew, could have been better if there was a human in the loop to override. And I think that's an important concept because that empowers trust. And I think that would allow better adoption in what we do with our patients with robotic surgery. Andrew, I got a question for you, since I know you're just about to jump on a plane. You're a very complex pancreatic robotic surgeon, and your reputation precedes you. But what kind of new things in autonomous or semi-autonomous computer systems are you aware of? I know that you also have tried SS Innovations Mantra, and I think that's an exciting tool, especially because it's built by a cardiac surgeon. But what do you see in the field of really complex GI surgery when you're using it for pancreatic? And what could you say, like new systems like that are helping us in adoption in the world?
I mean, right now, the biggest innovations really are in augmented reality to help us with anatomy, to help us navigate the portal vein and everything. And that's really the most exciting right now. For pancreatic surgery. For liver surgery, it's fantastic to have the portal anatomy intraparenchymally, so you can do parenchymal sparing surgery. So I think vision really is driving the field of HPB. But I do think autonomous actions are coming, and they're coming quickly. And we need to start using terms like DEXENEs and SurGenes, which are, just like we were talking about in the previous talk, is we're going to have parts of the procedures done autonomously, like a linear stapler by Medtronic, or the Signia stapler. It already does a gastrointestinal anastomosis autonomously. It has a sensor. If there's a problem with the tissue, it slows down, it speeds up, or if it doesn't fire, what have you. So that's already autonomy that we have. So there's many examples of autonomy. I don't know if you guys use ligature device in cardiac surgery, but that looks at 434,000 data points per second, uses a complex vessel sealing algorithm, and it tells you when to cut the device, not the other way around. Or even the Trump, the table, with the Da Vinci, the Trumpf table that moves, and the arms move autonomously as you're moving. So there's really so much exciting stuff that is already there, and the funny thing is that we haven't noticed it. So again, I think for visual stuff for HPB, but I think for cardiac stuff, as you saw with the Nadi device, if you can have autonomous anastomoses, vascular anastomoses, that's going to make your life very easy. And as you know, I believe Johns Hopkins has the STAR robot that can already do an autonomous gastrointestinal anastomosis or minimally invasively. So, what is it? The future is now, or whatever the cliche I'm looking for.
Andrew, I didn't understand the first half of your talk because it was all words that you use below the diaphragm. But just kidding. But I think Sloane Guy has raised his hand. He wanted to.
I was just going to comment that one of the problems that I've seen in cardiac surgery is, and I'm sure it's in other subspecialties of surgery, is we get so involved within our specialty, we don't pay attention to what other subspecialties of surgery are doing. So, one of my tricks is I go and learn from the urologist and take some little trick that a urologist is using every day, which is no big deal to them, and bring it into cardiac surgery, where it's like, considered to be this bold, crazy move. But in fact, it's used in other specialties every day. So listening to Andrew, I just thought it was pretty cool because I think we could probably learn in cardiac surgery a lot from surgeons that are doing the things that he's doing. We need to start paying attention to specialties outside of our own, because there's a lot of innovation in those spaces that we can bring into ours.
Absolutely.
Yeah, I couldn't agree more. We're actually writing a position paper for the European and African Hepatic, Pancreatic, and Biliary Association. And we're arguing exactly for this, is that we need to replicate what urology does. They control the endoscopy, they control the percutaneous aspect of what they do, and they of course control the surgery, and they even give chemotherapy, you know, for bladder cancer. And we need to replicate that model. Things are becoming too complex. Having gastroenterologists doing one thing, interventional radiologists doing another, and not having all of these people in the same department by organ, I think is an outdated mindset. And cardiac surgery, lesson from interventional cardiology. You know, you guys are all over those percutaneous stents. So, you know, this is the model that has to be replicated for, I think, for best patient care, to be honest. Not only for us to continue to exist, but I think the main reason is the best outcomes for our patients is if we have these silos of specialists that know how to do everything: endoscopy, percutaneous surgery, and of course, surgery and robotic surgery.
Andrew, privileged to get you to speak for us today and interact with the really cool guys that are here. So have a very lovely, safe flight, and thank you very much for joining us.
Thanks, Zane. By the way, I have a device I'm going to have to call you about shortly that you are going to love.
Thanks, man. Well, what a privilege. Andrew's a great guy, as you saw, and I'm so happy he got a chance to join us.